Good morning. Thank you all for coming. My name is Clemens, and I work in primary care and healthcare delivery improvement. We have an engagement problem in healthcare today. This is especially true for the most sick and vulnerable patients we care for in our systems. This is a problem that I think a lot about, and I'd like to share some of my thoughts with you today. Despite overwhelming needs, these patients spend only a small fraction of their days engaging and interacting with the care teams. When we reach out to these individuals to engage them in care, we're too often constrained by the clinics and the walls that surround us in our clinics. And too often, our caregivers, the care team members, and the office staff don't look like our patients, speak the same language, come from similar backgrounds, or understand the patients and the context in which they live and work to achieve health. My friend once told me about a patient named Ed. Oh, his name wasn't Ed. We'll call him Ed today for the purpose of this. Ed was a patient that she saw at the Highland Hospital, where she worked as a resident. Ed had many issues that he faced, and he came into the emergency department with one problem after the other. He would come into the emergency department, be evaluated by my friend. My friend would do the full workup and send him on his way. Ed would walk out the front door, and turn around, come right back into the registration desk, and check in with another complaint. Ed is an example of one of these types of patients that we sort of deal with. And my friend said it was like Ed was on a conveyor belt, circling in and out of the emergency department. Ed was poor. Ed was homeless. Ed faced so many issues that we as a healthcare delivery system aren't well equipped to address. But Ed also represents the failure of our delivery system to engage patients like him. So how are we failing? What's missing? I think a strong, continuous relationship is missing. Healthcare delivery at its core is relational. It depends on trusting relationships between patients and caregivers. And our systems aren't set up well to develop these relationships over time in many settings. Primary care is a setting in which we're supposed to do this. We're designed to do this. And for the past year, I worked with an innovation team at the Charlestown Healthcare Center here in Boston to try to address the needs of patients who use the emergency department unnecessarily. You can see our team there. If Ed were a patient of ours, he would have received a follow-up phone call after his visits to the emergency department. He would have received a follow-up phone call from Tracy. Tracy's unbelievable. She's really just this fantastically skilled nurse that is caring and compassionate. And she's able to have this, she has this innate ability to just engage patients. But I'm not sure whether Tracy would be the right person to engage Ed. And even if she were the right person, I'm not convinced that she could do it, given Ed was spending all of his time in the emergency departments and on the streets, day in and day out. So how can we transform care to better engage patients? I think a key part of the answer is to employ community members or community health workers as parts of our care teams. I'm going to let Ron Sanders introduce himself. He was a person that we hired in San Francisco.
By the time I was 7, I was raising my brothers and sisters. Our parents would throw these big house parties. The table was full of alcohol and bottles were everywhere. In the morning, I'd step over bodies passed out on the floor, take the bottles in the backyard, and drink what was left. When I was 17, I was drinking so much I passed out in class. But I enrolled in a community college. I got drunk, high with some kids, and we ended up stealing some guns from a liquor store. Ended up shooting at a dorm mate over $20. I ended up getting 3 years. That laid the groundwork for the next 14 years. I went in at 18, and I didn't finish until I was 32. Today, I am a community health worker working with formerly incarcerated men and women. Sometimes when I'm working with a client, I can see the same hurt and frustration that I had when I was trying to get my life back together. It motivates me to help them.
So Ron Sanders was the face of our primary care team in the Transitions Clinic, a program that we started in San Francisco to address the needs of patients returning home from prisons, both in the state and federally. Ron reduced emergency department, in our population, emergency utilization by 50%. This effect was even greater in those that visited the ED more than once. So how do community health workers address the fundamental issues in healthcare delivery? Well, Ron delivers engagement. He engages patients in ways that we can't. And he helps us better understand these patients in the context in which they live. He interacts with patients between clinic visits. He reaches out to them. And Ron saw patients up to daily at times when they had acute needs. He reaches and extends the care that we provide outside of the walls of the clinic. He engages patients like Ed in the community, and he brings them into the care system, into primary care, so that we can provide the care that we want to. And given his shared lived experience, the experience that he has that's in common with our patients, he's able to teach us how to better tailor our care interventions and how we can more effectively deliver our care to these patients. The Transitions Clinic is now the Transitions Clinic Network, and we're working to disseminate our model across the country. We have community health workers, 16 of them total, working in 13 communities throughout the US and in Puerto Rico. And we're working to improve care for the patients that are returning home from prison. But our sustainability is in question. And that's part of the reason that we've now begun the work of expanding our work through Anansi Health. This is an organization that I started here with Heidi Beferuz on the principles of Partners in Health and on the work that Heidi did with HIV patients in Boston through the Prevention and Access to Care and Treatment Project. Anansi Health is working with organizations, health systems, and communities across the country to effectively embed community health workers into the fabric of care delivery. And we're working with the highest cost, highest risk Medicaid patients and dual eligible patients in these communities. And we're doing it, patients like Ed, really, in many respects. And we're doing this because we think that we can demonstrate a return on investment. A return on investment that might convince the powers that be to engage and employ this powerful workforce in the way that we deliver care. But we can't stop there because of the immense potential that community health workers have to both engage our patients and our healthcare delivery systems. I think we need, in addition to that, we're going to be able to provide jobs for these patients in these communities, in these vulnerable communities that really desperately need these jobs. But what if we could capture some of that savings, some of the savings that we generate in our programs through Anansi Health, and start to work upstream, to invest in community health infrastructure, to spur community development, and to eventually address the issues of poverty that plague our communities, to address the needs of patients like Ed over time. I think it's time to unleash the potential of community health workers to accompany our patients to better health and our systems to better engagement. If we want to improve the value of care delivery in the United States, let's focus on relationships. Let's take some of the $4 trillion we spend on healthcare in the US and invest in 500,000 community health workers, 500,000 Ron Sanders, and then see what it does to our ability to engage patients and improve their health and the health of our communities. Thank you.